start to introduce our speaker, Professor Mary Ott. I'm Peter Schwartz. I'm the director of the IU Center for Bioethics and the director of the Bioethics and Subject or Participant Advocacy Program for the Indiana CTSI. And I'm just thrilled to welcome you here for one of our favorite topics and one of our most favorite people to talk to us about community engaged research. Professor Ott is just the perfect person, I'd say basically the only person on campus to do this talk. She is a professor of pediatrics and adolescent medicine, researcher and provider here at the School of Medicine, and has for years been a key member of the bioethics program for the CTSI. A lot of her work has involved ethics around community engaged research, partially because she actually does a good deal of community-based research and consulting on community-based projects, but also because she has a tremendous expertise in this, lectures widely. And today she's agreed to do our treats talk on this topic, a 20 to 30 minute talk, hopefully, sort of a primer for people who may not have much background on this, who are probably fast forwarding through this intro right now. All these talks are recorded and provided live on our website for people who might want an intro, and then to contact the bioethics program as needed for consultations. If you just search for the IU Center for Bioethics and look under our research ethics tab, there's links there and through the CTSI websites. Anyway, again, we're lucky to have Professor Ott doing this lecture. I'm thrilled. I'm looking forward to myself, and I will hand it over now to Professor Ott.
Thank you, Peter. So I appreciate everybody who's online. And if you're comfortable, I'd ask you to show your faces. I may ask for some participant input into this. And so you can either unmute and say it or an answer, or you can put it in the chat, and Nick Oliver will be monitoring the chat. So, and I wanted to make it really pragmatic. So I have this is 8 considerations or 8 things to take into consideration when we're thinking about the ethics of community engaged research. And what I'm going to do is I'm going to use cases to illustrate each of these considerations. So I want to start off with core principles of community engaged research. We typically think about autonomy, beneficence, and justice. But when we're thinking about community engaged research, we need to add on dignity, and dignity differs from autonomy, and that dignity really has dignity is the right of a person to be valued and respected for their own sake. A person might or might not have autonomy, but they can always be given dignity and be treated with dignity. And then the other core principle is this idea of empowerment. So enabling autonomy and self-determination in both people and communities, with the purpose of allowing them to act on their own authority and representing their own interests in a responsible and self-determined way. So this is this idea, we want to empower people and we want to treat them with dignity. And I sort of use focus on these 2 core principles when I'm working with communities, rather than thinking through autonomy, beneficence, justice. Although my equity colleagues say all of these fit under the umbrella of justice. So I'm going to skip this. So I'm going to start with I'm going to do sort of a little bit of a countdown to 8. And we're going to talk, and these would be considerations that we should take into account. So the first consideration is, who is the community? And so keep in mind, who is the community? So colleagues of mine wanted to design youth-friendly antenatal care services in Western Kenya. So half of all Kenyan women in their area have children of teens, and teens have higher maternal and infant mortality rates. Teens also less than half of teens receive the recommended 4 visits or deliver in a facility, which in a low resource setting is really important. So their recommended number of prenatal visits is 4 versus 13, and for an uncomplicated pregnancy in the US, the median number of visits for teens was 1, which means they went once and didn't go back. And delivering in a facility makes a huge difference for neonatal mortality. And when my colleagues looked at this, they talked to youth and they talked to medical staff. The youth felt judged. The medical staff felt the youth were not adherent. And so the purpose of their project was to use a human-centered design approach and develop an adolescent-centered pregnancy project. And they did in-depth stakeholder interviews. And then they put together a community design team, and they did design labs where they would like look at design to identify characteristics of ideal antenatal services. So my question is, like, who is the community in this? And if people are online and on their chat and could dump it in their chat, that would be super great. If we have any sort of thoughts on who should be at the table, like who should we be considering community for this? So definitely the mothers. So we're talking about the adolescent mother, right? When we're talking about adolescent, including adolescent mothers, it's like the mothers. Or the next question, the next comment is families of pregnant and parenting teens. Julia has put in tribal leadership and men, and that's sort of an interesting 2 different types of things. Any other thoughts? Yeah, and then Carolyn adds in providers and clinics, so taking into account the health system. So as it turns out, all of these individuals were their communities. So when they started to do stakeholder interviews, they needed to do stakeholder interviews at all levels, like community leaders, young people, families of young people, healthcare providers. So there is a saying that comes out of disability rights, but has really been adopted much more broadly, and we see it used in community engaged work, is this idea of nothing about me without me, and really the importance of having the community that's getting intervened on be not just a part of the project, but to be core members of the team. So the big question is, I think, is like, who should be sitting at the table? Who's included in community? And some pragmatic things that flow from that is like, how do you recruit these? Like, how do you recruit the young women that are that you're going to, the teen parents? Are they teen parents who delivered in the facility? Are they teen parents that attended? Are they teen parents that didn't attend? Are they teen parents in community settings? What format do we want? So not just for this project, but for any project where we're thinking about engaging community, what's our format for community representation? We could engage with formal leaders. We could put together community advisory boards or youth advisory boards. We could have youth leadership teams. Community members can be part of the research team. And then, so thinking about like how, when you engage with the community, what's going to be the vehicle for doing that? And then what are the relevant power dynamics? I mean, what ended up being really important with youth focused work, and is across the board important, is like youth are relatively, even compared to like parents and community leaders, but certainly compared to researchers and medical providers, there's a real huge power differential. And so frequently we end up sort of over recruiting youth to participate. One project where we had youth engaged, and I'll talk about this a little bit more later, as part of a public deliberation, we actually did training of youth, so that before the deliberation, so that youth would feel comfortable presenting their perspectives in a virtual room full of adults. So any questions on who the community is? So our second one is like, and this is like, so a second part is like community consultation, like, and this is gets at this idea of how do you consult them, when do you consult them, where do you consult them. So this is another Kenyan project. So in HIV prevention, voluntary male medical circumcision is a highly effective intervention to prevent HIV. So for locations where there's a high HIV prevalence, it should be a part of the toolkit for HIV prevention. It turned out in this part of Kenya, young boys were circumcised as part of a family rite of passage as teenagers. But boys who were street involved generally were not circumcised because they weren't living with their families. They didn't have access to these types of community and cultural resources. And it elevated their already high risk of HIV. So one of my colleagues, Paula Breitstein, was put together a new intervention to provide voluntary male medical circumcision and sex education to Kenyan street boys 12 to 17 years of age. And they did this through a coming of age retreat. They'd included coming of age activities, like what does it mean to be a man, that are normally a part of adolescent circumcision for teens living with families. They had the 4-day retreat, the voluntary male medical circumcision, and then they got a waiver of parental consent they requested a waiver of parental consent because the young people weren't living in families and there really weren't parents to consent. And so at that point, they looked at like, what's the next best thing to do? And so there's this idea of community consultation in bringing the community in to help understand what's the best way to make research safe and respectful of community processes. So community consultation, and some people call this community consent, although my regulatory colleagues remind me that consent is something an individual gives for themselves, but it's sort of this idea of community consultation or consent is a way to incorporate the perspectives of the participants. It allows bidirectionality of the project, and it allows shared moral authority. So by consulting with communities, the community takes on some of the responsibility for the project and for the successful completion of the project. And it adds an extra layer of protection for vulnerable populations. So my colleague Paula had met with elders in the community leaders. She met with medical providers. She met with the street youth in this section of Kenya, or organized into barracks with like sort of young adults who had grown up in the streets. As leaders, she met with leaders within the barracks. She worked with a Kenyan sociologist to design the cultural intervention. And so, so she did this extensive period of community consultation before implementing the project to make it bidirectional, to incorporate the perspectives of important stakeholders, to share moral authority and protect the young people. So this other piece is something that I've been working on a project using a method called public deliberation. So again, thinking about HIV. So Paula's project was an example of a biomedical intervention for HIV prevention. And a biomedical HIV prevention is a situation where you use drugs or devices or a surgical procedure. And the question comes up is, like, HIV is a very sensitive topic. Should minors consent for HIV prevention research when it's a biomedical prevention approach versus a behavioral prevention approach? Or should we be getting parent consent, or should there be another type of consent. And when we interviewed like stakeholder groups, young adolescents and young adults were for it. They said absolutely they would never consent if they were required to get parental consent. Parents and university legal counsel were absolutely against it. Parents felt very strongly that young people shouldn't be able to consent for research that had this degree of physical risk without parental consent. And investigators and IRBs were worried and trying to find a balance between respecting minors' rights to consent, respecting families, in protecting minors, and providing minors as a category access to critical HIV prevention research, because what we've seen in the past is when biomedical prevention initiatives come out, it can take up to a decade for children under 18 to have access to them. So the one group that wasn't consulted were communities that were most affected by youth HIV. So we proposed a public deliberation. And so what we did for our public deliberation is that we sat and thought, like, who's the community, and use the deliberation as a means to get community, to assess community, to consult with the community, sort of just discuss to figure out where they felt on it. And when we did it, we made a deliberate effort to, we had site teams, and we deliberately recruited those communities who are most affected by youth HIV. So we, in the US, these are HIV primarily affects Black and brown young men, and young gay men and trans women particularly. So we worked with LGBT groups, we worked with African American community health organizations, we worked with investigators and HIV prevention groups, we worked with schools who worked with the young people, other youth agencies, and we recruited a fair number of youth. So we had youth families from these communities and care providers from these communities sort of coming together to talk about minor consent for HIV research, thinking about both this idea as who is the community and can we get some type of community consultation on it. Any questions? You can dump them in the chat and Nick can pick it up. So if we don't have questions, I'll move to like my third thing is equal partnerships. So in this case, a community organization that I've worked with was applying for a federal grant to implement an adolescent pregnancy prevention program. The grant required an outside evaluator, and they approached an IU School of Medicine faculty member. Both groups were invested in making this an equal partnership. So my question for the group is, what hard conversations need to happen? What things do you need to talk about as part of this grant process? So Lynn has a question about observations of the process of public deliberation. Yes, I'm gonna table that question to the end and come back to it. It was a really interesting process, but I'm going to go back to my sort of equal partnerships piece. So what do we need to talk about for an equal partnership to happen?
Should have benefits for both partners or for all partners.
Yeah, it is certainly like benefits for all partners, and those partners need to be the ones that determine the benefits, like not me sitting in my ivory tower. Any other comments, or people can dump a question or a comment in the chat?
I would say trust and transparency.
Yeah. And I think like trust and transparency is super important. In particular, like there is this ethical principle around like truth telling and veracity, and like giving people enough knowledge and enough information so that they can make a reasoned decision for themselves. So a lot of it is like equalizing power relationships, and the things that we did and I'm going to say as a background point, there's a lot of disincentives for academic partners to have equal partnership. Our academic currency is our being PI on the grant. NIH funding is preferred. We are judged on peer-reviewed publications, which really isn't the case for our community partners. We want, like, and this has been a controversial topic within the university, but indirects end up being really important. And the loss of indirects for funds to go to community partners is something that happens. And indirects are complicated on non-NIH grants where the indirects are written into the total. So these are like these little subtle things, but comes down to like US, like to money in academic currency. Other pieces are around data and who controls data ownership. The need to get IRB approval is helpful for IRBs tend to go through more smoothly when everything is in the IU School of Medicine and there's more control. The need for like sort of rapid turnover at times. So all of these are sort of disincentives for academic partners to do community research. And it's built into our academic promotion system. But we really do need to have hard conversations around budgeting. How much goes to each partner, to whom, who's going to be the PI on the grant? When I've applied with community partners for grants, oftentimes they're the PI and I'm a subcontract, because then they have more money because the indirects need to be built into the grant, into the total, and there's more money for programming if it goes with me as not the PI, but me as the evaluator and them as the PI. I've coached community partners on indirect policies for their organization so they can recoup some indirects. What resources and compensation go to communities? Like, what are our procedures to make sure that we keep equal partnerships? So like procedures, meaning I see there's been several comments on communication, and this idea of open communication requires like not just a willingness to be open about communicating, but I think really like scheduled meetings end up being really quite important, because things that I don't think are important, we talk about in community meetings and end up important to my community partners. Things they talk about as important, they don't think are important to me. So open communication. So these conversations, and if you can have them at the front end, it's really important. Ownership of data ends up being a really critical issue. I have a gentle person's agreement that nothing goes out without the other person. And we do it both ways. Like I will oftentimes get a text at like late in the day, say, hey, we have something that needs to go out. Can you look at it quickly and make sure when we put out abstracts, student papers, things like that, it goes the other direction to the community partner beforehand. So a lot of pieces need to go together to have equal partnerships. So staffing for capacity. The pregnancy prevention grant is funded. So this sort of flows from sort of this idea of equal partnership. How do you apportion staff among community and university partners? How do you do this in a way that builds capacity? And one of the things that I have done is set up a long-term goal with my community partner is to build their capacity for research and evaluation. So we have always had more staffing on the community side and then run a really slim shop on the university side. With really minimal staffing and staffing that's not available on the community end. So like with a focus on analytic skills. We've done community training for our community partners in city and red cap and evaluation methods and implementation sciences. And in the weekly meetings, we discuss methods as well as results. And with this idea that, like, after working with my partner for 10 years, I can step away and they can write an evaluation section for their federal grant that's like strong and fundable. And they have staff within their organization that are capable of putting together surveys, things like that. So 5, IRB representation and input. So a colleague of mine in Chicago does a lot of work in HIV prevention, and particularly has worked quite a bit with trans youth. And he was looking at trans female HIV prevention. There was a CDC grant that came out, and he wanted to adapt an adult intervention called HIV prevention intervention called SISTA, and he called it TWISTA. And they were going to recruit 14 to 17-year-old females, trans females living out of home situations, and provide intensive sex education. And they were working closely with an LGBT youth serving organization and health center. And he sent it to the IRB, and the initial review, they had enormous concerns because there were very explicit questions about anal, oral, and vaginal sex, sexual coercion, and drug use with sex. The IRB, including their community rep, felt that it was inappropriate for minors, but really like worried about making the minors uncomfortable and reinforcing the stigma that the young people would have. And so in this brought up this issue of community representation on IRB, particularly for people working with communities on stigmatizing topics. And so when we think about like our colleagues working in substance use, my work is in reproductive health with young people and HIV prevention. It can be like the IRBs are required to have a community representation. Sometimes the community representation is provided by a partner in a law firm who has some sophistication about regulatory matters, and is a way for their firm to give back to the community. Other community members have been pastors or other religious leaders. And so the community member may or may not be come to the table with knowledge or about working with particular high-risk communities or with education. And so there's like, I think this is something for community researchers to really think about like what sort of community input do they need to bring. My colleague had the LGBT youth serving organization write a very strong letter of support where they said that these young people were already exposed to these risks. And in fact, the education, although it felt explicit on the surveys and in the education, would actually be protective and empowering of youth, and was able to work with his IRB around that with the support of the community organization that he was working with. So I think this thinking through like what's happening with IRBs and community representation, and particularly for work on stigmatizing topics or with hidden or vulnerable populations. And so like there are different ways to address this. One is like having community members that work with vulnerable populations or hidden populations join an IRB and be the community representative. Another way would be to get community input to bring the results of your community consultation to the IRB and sort of allow, which, you know, to provide them with this information of like, here's the community, here are where they come down on the topic, and here are the protections that they would want to see in place. So 6, risks to community. So this is sort of a classic case, but there was a researcher who wanted to look at alcohol use disorder among Navajo adolescents, and they proposed an epidemiologic study to determine the rates of adolescent alcohol use and risk factors for alcohol use disorder in young adults. The data would be used to design a longitudinal intervention that targeted risk factors. They approached tribal leaders with their proposal, and the tribal leaders declined, citing community risk. So my question is, like, what kinds of risk, what are these community risks, and how could the researcher have addressed them? And you can unmute or you can dump it in the chat.
Does it help at all to find out what the tribal leaders were afraid of? Was it stigmatizing their community? And could it have been a reassurance that they would keep it all confidential about which community it was?
Yeah, so I feel like you've actually said a couple different things, Peter, and then Jane has dumped into the chat, like this idea of reinforcing damaging stereotypes. And in this case, it was like reinforcing damaging stereotypes. And, and there are a variety of different kinds of risks to communities. Some type of risk undermine the organizational authority and the validity of the community. Sometimes it reinforces stigma and perpetuates social exclusion, which was in this case. Sometimes it focused on risk to the community rather than strengths. And again, that was a problem with this one, where it really, instead of looking at protective factors that would prevent adolescent alcoholism, they really focused on risk factors. And then you do get to privacy and confidentiality, which are always important ethics concepts in research, but in particularly in community research, they play out a little bit differently. So, and I'll talk about that. So back to the prior case, so the TWISTA project, the HIV prevention intervention for trans female youth, hired trans women as facilitators and research staff, and then sort of thinking like risks and benefits, particularly around confidentiality and privacy. The benefits are really clear. Like, this is a capacity building thing, the same way I apportion some of my research funds to like have people within the community agency take on these roles, learn the roles and develop skills in them. So like by hiring within a community, you provide skills and training that stay in the community. You provide meaningful employment frequently in communities where there aren't a lot of employment opportunities. And then there's sustainability to the intervention. If the facilitators are trained from within the community, you build like this capacity for education within the community. You get community perspectives on the research team, which can be really invaluable, particularly when you're having difficulties with recruitment, consent, drop off, or participation. It can enhance the trustworthiness of your team and provides the team with access. But on the flip side, you end up with privacy and confidentiality risks. And privacy has to do, and that's the two individuals talking over the fence. It's like people knowing your business, but by virtue of being a research staff member, someone in the community may have access to more information about other individuals in the community than they would normally have. And that information may be stigmatizing or maybe harmful information. And so that requires like a lot of intensive training and a lot of self-awareness on the part of the staff members. The other piece is confidentiality, which is protecting personal information. And that's really a data security. That's the laptop. And I put a laptop to remind myself that I have been involved in projects where laptops have been stolen out of cars. And so you almost need like a police, like chain of evidence types of things, like when the data is collected, is it collected electronically with electronic capture approaches and through an interface? Is it collected via paper? A lot of times electronic data capture is great because it goes like directly from the person to the database, not resident on the device. So if the device is stolen, it's not a big deal. What is a big deal, but it's not as big a deal. I mean, other times, like when we're doing surveys of a large group of adolescents, it's not feasible to do it electronically. And we hand out paper surveys, we make sure they're numbered, we put them in an envelope. You have to take the envelope, you have to get it to the right place where the data get entered. So thinking about like the data security, where it's resident, who has access to it, if it's electronic, is it encrypted, password protected, not resident on the device. So these pieces become particularly important when you're in community settings. 7 is return of results to communities. So the Rural Pregnancy Prevention Project has been completed. We had community and youth advisory boards. The youth advisory board was actually a youth leadership council that did really cool activities. There was extensive community outreach. There were lots of surveys and interviews at sort of all levels of the project. And the question is like, how then do we return results to communities? Like, what's the right way to return them? And it's hard because there's like community dissemination versus academic dissemination. Like community projects are like reports that are front and back side of a piece of paper or electronic version of that, or an infographic, or a community presentation. So for this particular project, we did like a rapid analysis of the final results so that we could do a community presentation on it. In the academic world, the product is a manuscript, which may take like 6 months to write and another 12 months to get published. Or presentations at academic conferences where you submit your abstract in September and the conference is in February. The turnaround time on the community side is usually rapid because they want to build on the community interest and engagement and provide the data at a time when people are interested in it and thinking about it. And also they're going to need to use the data for programs and for project and implementation grants so that they need to get the data to their funders, as opposed to the academic side where the turnaround time is a little slower. There's more extensive analysis. We're looking at applying for NIH grants, which are also sort of long-term things. Sorry to be missing the T. And the types of analysis for community work are really basic analysis, looking at the reach, effectiveness, implementation, applied work. Whereas on the academic side, we're going to look at complexities around measurement, complex models, and really advancing public health science. So there's a disconnect on the dissemination products. And again, like one of the hard initial conversations that we frequently have is, what are the dissemination products and what's the timeline for dissemination? So this is an example of one of the dissemination projects that we were using. The Educating Communities for Healthy Outcomes project in rural Indiana counties looked at sort of the co-occurrence of HIV and substance use in teens. And so it was a prevention program that targeted adolescent substance use. And this is an example of the infographic that my community partners put together. And it really focuses on some of the things that I talked about. Reach, 905 students were served. About a fifth of the students had vaginal sex, and a similar number had anal sex. So we looked at like substance use, 50% had used alcohol, sort of going down to 21% using marijuana. So they're really focusing on what are the reach, what are the risk factors, and then what's the impact, which is really different than papers coming out, where we took some of the data And we looked into like tapping into community resilience and rural adolescent pregnancy prevention. And so that these outcomes are really different and our products are really different, and both need to be addressed and assessed for the partner to have an equal partnership. Okay. And then the last piece is handling unflattering results. So this came up just recently. I was helping conduct a pilot of a court-based sexual health education program with my community partner, and our goal was to increase referrals for contraceptive and sexual health services. And of the first 100 participants, only one of them actually ended up getting referred and then following through with a referral. And so I was like, it didn't work. And so one of the things to talk about would be like, if you have data like this, like, how do you handle it? Where does it go? Who does it go to? How is it interpreted? Holding the conversation early is really important so that you have a sense of how the agency or your community partner would feel about unflattering results. And then sort of like, as the preliminary results were coming in, we like talked about it again and like holding it early and often. One of the pieces for this project was really putting it in their lap and having them interpret the data. So not only did we have data on the number of referrals, but we had like needs assessment data on the kids coming through the courts. And previously we had really high risk kids coming through the courts. And because of some changes in court procedures, we actually had a lot of lower risk younger teens coming through for whom a referral might not have been appropriate. And so when we talked to them about interpreting the data, they looked at it from a systems perspective, which I had not initially taken. The other thing that they looked at were secondary outcomes. And we had secondary outcomes around education that actually looked pretty good in this. And so thinking about like having my community partners interpret the data really enabled them to use it in an effective way. The other piece was sort of considering risks to communities and organizations as well as individuals about data. And again, like, I feel like allowing my community partners to interpret data was my sort of approach to sort of addressing some of those risks. So our ethical considerations summarized for Peter. Who is the community? Has the community been consulted? Is this an equal partnership? What do you have to do to make it equal? Does your project build capacity and sustainability? Sustainability is something I forgot to say in the slide, but really thinking about, are we doing this in a way that will continue after we as academic partners step out? What is your IRB community representation like? What type of input would they like? Do they need? Should you be providing with your projects? What are the risks to the community, not just the individuals participating in the research? How will the results be returned to communities, and what to do if they're unflattering? And I am open for questions. Oops, wrong direction. And I'm going to stop the share so people can see each other if their things are on.
Oh my God. Wonderful, Mary, as always. And that final slide will be the thumbnail we're going to put on the treats page. That's the list, and you summarized it perfectly and give us great examples for each one. So I'm sure there are questions. I'll let you field those.
Okay. So I have one outstanding question from Lynn is, can you share some observations about the process of public deliberation, how the process went? Lynn, I can say that it was very much a learning experience. The first piece of it is we actually had done the deliberations virtually because of COVID. We had initially wanted them to be in person. But the project was funded in January 2020. And so it was not in person. And we had it was done in communities outside of Indy. One of the biggest things was having a champion. When we had a strong champion in the community, it really, everything sort of flowed. Like they facilitated recruitment, they facilitated introductions, so that was super helpful. The other piece was when we're involving young people, we really needed to have a high number of young people participate, and the young people needed training. And we started out the project with this estimating that we would recruit like 25 to 30% of deliverants would be young people. We went to a youth advisory board and the kids were like, no way, like you have to have at least half the people have to be young. Like otherwise we will just feel like we can't say anything. And we weren't always able to maintain that many young people because sometimes young people tended to fall off more than adults, and sometimes we had trouble recruiting them. The other thing that we found was that young people really did way better when they had training. And what we observed in the first couple of deliberations is the young people who were already members of advisory boards sort of knew how to talk to adults. Young people who weren't tended to quiet down more, particularly when an adult talked over them. And so Carolyn Mayer, who's on this, put together a training program for young people for holding their own in like mixed adult young people advisory boards that was really like the young people really enjoyed it, and it enabled them to be more active participants. And then the last thing was like there was just sort of like not, it was not a predictable, like the results the results weren't what I would necessarily have predicted. We saw a lot of people that started out as like, yes, minors should absolutely consent, and be like, well, these people who like want to protect young people have a point, and sort of, and then we had people who were like, absolutely only parental consent, were thinking that then they were like, well, you do have a point that not everybody lives in a family with functional parents. There could be risks to doing this. There could be other ways to protect young people. And so we had a lot of discussion and sort of migration and change. Each site that we did it in 4 sites had like slightly different final recommendations, but like all of them moved towards the middle, and all of them there was a lot of change going on, a lot of people discussing things, even up until the last day and the last minutes of the last day. Andrew asks a question about when might an independent third-party mediator or negotiator be useful for partnerships? Yeah. They can be useful when partnerships fall apart. You know, sometimes it's not a bad idea to have like an idea of a mediator, a negotiator. And I'm not sure, I'm thinking like, you know, like if you have an idea of someone who might function in that capacity, it would need to be someone who's like, if a partnership is falling apart, if there's someone that's trusted by both parties, could bring them together and encourage them to discuss. And I don't know, Andrew, do you have any other thoughts on like situations that might need a mediator, negotiator?
I don't really. But I know the challenges of when you mentioned the power dynamics, and when communities are particularly initially engaging and their awareness and understanding is maybe making them feel vulnerable, having someone who third party assisting them in balancing the power. It sounds like you do some really helpful things to give them that empowerment, but I wondered if a third party person could be hired on staff wise that would facilitate that.
It's an interesting, so I think, you know, what you're talking about in essence is like what we like a community champion, and having a champion within the community, someone who has a relationship with the research team, but also has a relationship with the community. So in our public deliberation project, we had, like in Tampa, we had two champions. One of them was the site PI, but one of them was the research staff member who had deep connections and was this like very trusted individual in the community. So I think they can function as a champion, as a bridge. You can use the person around problems. So if there are unflattering results and you need to like have someone help mediate how to interpret them and what to do with them, I think that's a situation as well. Any other questions?
Karen has a question in the chat. She asks, how does your engagement with the community change when the project is over?
Yeah, so I think a piece of it is the type of relationship that you have with the community, because I've had ongoing relationships where we have like multiple projects and multiple pieces that we do, but sometimes there are things where it's like a one and done type of thing. I think negotiating, there's a couple things. The first is like making sure that it ends, like there's a plan ending, and that both sides, I shouldn't be thinking about both sides, but both the academic and the community partners leave with like their expectations met, and both of them have the products that they need. So I think that like if you have a community project where you know that you're going to interact with this community and then step out, like thinking ahead of time, like what are the sustainability and capacity things? What do you want to leave in the community? What sort of ending types of things, and having like closure. I did a study where we looked at young men in STD risk at Indiana communities, and it was like a bit of a needs assessment and an epidemiologic study to get a sense of prevalence. And we really ended up, but what we did was we made sure like each community partner had their data in like a digestible format. So they got, and then we did like a closing ceremony where I had a colleague who was this really amazing sociologist who did work in masculinity and men's health. And we had like, you know, an evening at the HITS building where like all the community partners were invited. We were able to put together some funding to give people food, and we had every community agency got a folder, and then young people who are on the advisory board talk. So if you can have like some closure, giving back, and then we had hired from within the community, so the community partners knew that there had been people who had been making salaries, getting references, things like that. But I think it's like an important piece is to think about like what happens when you close, what does the community need? What do you need to maintain the connection? Any other questions?
I have one. Once you've identified the community members and the stakeholders who you want to continue a conversation with for doing your research, how do you begin those conversations? How do you introduce yourselves and start building that trust?
Yeah, I think a lot of it starts with an informational meeting and just get a sense of like what their organization does, what their needs are, what your needs are, to just sort of see like what their personality style is. Is there a champion? There are like sort of some things that are sort of going through. Does this look like it would be a potentially good fit? And then I think a big piece of it is thinking about like, what are their needs? What are their desires? What would they like to see? You know, what would they like to see in a partnership? I sort of have an idea of what I would like to see, but I want to know sort of what they need, and can we make the two mesh to make it as equal a partnership as possible.
And we live in a time where people are eager to say that everything's changed since COVID. Have you seen a change in the last couple of years in how to approach these sort of relationships, or then how to move forward from the relationship to the project and through the project?
Yeah, I think so. It's an interesting question. So, like, one of the things that's happened with COVID is that community orgs are much more fragile because of funding and staffing and things like that. So, I think that needs to be like front and center. And thinking about how, like, so I think that is a piece that has changed. Communication and data collection are really different. I have one long-standing relationship with a community partner, and we just moved all of our meetings to Zoom. I have to say, like, it's awesome. Like, everybody keeps the camera on and we talk, but it really, like, we kept doing the Zoom meetings so we didn't have to get the car and drive across town to meet with each other. And we sort of periodically get together and make it something special. But like the use of like Zoom and things like that, and it has shortened distances, right? So like it's really easy to talk with community partners and to do interviews. We've done interviews with individuals in Clinton County and Johnson County and Madison without having to physically go there. It's sort of funny. We've done a little tiny bit of work with youth who are incarcerated, and they don't have like Wi-Fi or cell service or things like that. And we have to go back to sort of old school physically going there to work with the facilitators. So, so the communication piece, the fragility piece, making sure that we are giving them what they need so that they can like write for their next community grant as well. Any other questions?
I guess we're done, unless somebody wants to ask the final question. I'm sure Mary is happy to respond. I will simply do this since you're, so I'm going to share my screen to show you how to request a consult from the bioethics program of the CTSI. Just go to this link that I put in the chat, go down to the bottom, or of course you can just email email account called bsap.iu.edu or just me, or any of the faculty members of the bioethics program of the CTSI. So, Mary, I cannot thank you enough. Just a great talk. Again, we'll put your 8 points in the description of the talk. Nick is doing that right now as we speak. We'll be posting the recording with, perhaps you can give us a couple of publications to put up, just people to